There are 8.1 billion people in the world, but in America, there's only 4% of that population. And why is it that Americans seem more stressed? It's because we tend to cram the 24 hours that everyone has and do a whole bunch of things, therefore neglecting our health, which then causes us to go to the ER. But what if you had the chance to sit down and chat with a doctor like Dr. Rick Ammar? Take time to talk about your health, getting exercise, also monitoring your blood pressure to prevent you from going to the ER, right foods. So in this podcast, we're going to sit down and chat with Dr. Rick Ammar, and he's actually going to help answer some questions that a lot of people have. Let's roll.
My first question is, what are some common symptoms that people dismiss or that they think is normal, but actually it requires medical attention?
Well, I can only speak to the cardiology world, but I honestly think the smartest people just notice, you know what, a year ago I could do this, like cut the grass, say, and not stop, and this year I'm having to stop a couple of times. That is not normal. Sure, a person slows down over time, but if last year you could mow the grass, no problem, then take the trash out, and now you're doing the yard in thirds, that's a problem.
Wow.
Certainly pain in the chest, the common heart, for many heart problems, there are common symptoms. Pain in the chest, trouble breathing, swelling in the legs, feeling funny heartbeats, feeling like you might pass out, any of those things. Yeah, that's not normal. So get that checked out. And there can be other things specific to different problems, but those are very, very common.
That's
very
really
common.
good.
Yeah, a couple years ago, my dad was having hiccups, and it was going on for a month, and he went to the ER, but it was a 4-hour wait, so 2 hours in, he was like, let's just go home. And so finally, a couple weeks later, he was still having the hiccups again, and apparently it was a heart attack. And they were like, wow, good news came in.
What?
That's an unusual first symptom.
Diabetes,
yeah, that's an unusual. But diabetics and women do not fit the textbooks.
Really?
Yeah.
Very often. But that's true of anybody. Like I say, the most common first symptom of heart disease is you fall over dead. So that's a rough first symptom.
Wow.
But when God designed the human body, there is very good wiring for sensory nerves in your hands. So if you poke yourself in the finger with a pin, it's going to hurt right there.
Yeah.
But if you poke somebody in the heart, all bets are off. Some people will say, "Oh." Other people say, "Ow." Some people say, "Ow." Some people go, "Oh." And some people don't have anything.
Wow.
So it can be anything, and hiccups is an unusual first symptom, but I've heard things very strange, for sure.
That's insane.
I know.
Wow.
And that makes a good point about people going to the ER and then waiting, and they're like, well, I'm waiting
Wow.
so long, I just want to leave. Yeah.
That's a good point. That's a really good point.
Another question I had, are there any new emerging treatments or in cardiology that you're excited about personally?
Oh yeah, that's legion. Cardiology, one of the really fun things about being a cardiologist, there's two things that I really love about cardiology. One is it's a common problem. Half of America, this is what takes you to your grave. So it's constantly being studied. People are interested in coming up with new things and whatnot. So there are new things all the time. And it's incumbent upon us to keep up. Well, I'm kind of a learner kind of guy, so I can't stand to not be on a learning curve. And if I ever I'm not on a learning curve, then I'm either getting another degree or so I'm always doing that. I read voraciously, and I love that aspect of cardiology. there are, so not only are there new techniques and new toys and all this kind of stuff, there's also new medicines. And cardiologists study things. So there are some things in other disciplines of medicine that are very frustrating that we don't know the answer to. Just to throw this out there, and I don't mean to pick on them, but it's not clear if a postmenopausal woman should take hormones, and who should and who shouldn't, and all this, because there's some risk of getting blood clots and all that. I don't think that there is an undersupply of subjects to study who are postmenopausal women in America.
Right.
This is an answer we should know. And I don't feel like we have clarity on that. In cardiology, we study things. So we, there are not 10,000 patients in a trial, there are 10 million patients in a trial. Are in various trials for different things. And, I don't want to say that we have certainty about some things, but we have clarity, I'll put it that way, which helps us give people really solid answers. And I rather like that. I mean, I like to be able to give somebody advice that I think is really backed is backed by some pretty good information. So lately, as an example, the heart failure guidelines for us have changed and have created this structure of medications that are amazing. So this, now it's incumbent upon us to get people on those medicines, make sure they can afford them, make sure they can tolerate them, and get them on proper doses. But boy, an individual cardiologist would typically have 5 years ago 4, 5, 10 patients in the hospital with heart failure. I haven't had a patient with heart failure in the hospital in months.
That's so cool. Wow.
Yeah, and it is a matter of aggressively getting on their medicines, following them up carefully, making sure they're taking their medicines, and some of those people need to be seen often.
Right.
Some of those people need you.
Yeah.
Right?
Yep. Repetitive education.
For sure. And need somebody to look at them, and they need, they need a family member to check on them, to make sure they're getting their pills and, not eating, bags of pretzels for lunch and those kind of things. But that's really cool stuff.
Wow.
We also are increasingly taking care of procedures in the outpatient setting, not just outpatient hospital, but in ambulatory surgery centers, for example. So most of my procedures now, heart caths or vascular procedures or whatever, are done without the person landing in a hospital at all.
Wow.
So it's wonderful.
And the recovery is quick.
It was, so I did a heart cath today, accessed the guy's wrist. He was at our ambulatory surgery center for about 3 hours.
That's it. Wow.
Home.
That's pretty cool. That's really neat.
When I started in cardiology, a heart cath was 2 nights in the hospital.
Wow. 3 hours.
Now it's 3 hours, from the time you left your driveway till the time you returned to your driveway.
Wow. So kind of like, if you don't mind, since we're talking about heart caths, do you have I wanted them to kind of go into like the actual procedure of a heart cath, if you don't mind.
Sure. So a standard issue cardiac catheterization. So what a catheterization means is a catheter is nothing more than a tube. It's got to be long enough to get from the point that you stick it into the blood vessel to get to the heart. And often it has different shapes to allow us to manipulate it to get just to the right spot. But so a catheterization is placing a tube into the heart to do something. And that doing something is typically measuring pressures, injecting X-ray dye to make images of something, or to deliver equipment to make something better, like a balloon or a stent.
Okay.
Right.
Yep.
So back in the old days, meaning like 6 years ago.
It's true. I mean, healthcare. Yeah, that's true. Yeah.
Yeah. Back in the old days, all of these were done by accessing the big blood vessel that's in the leg, in the groin.
Yeah.
So there are a couple of things about that so all the equipment was originally designed to be used from that location to get up to the heart. Every blood vessel, every artery leads to the heart, or else it isn't an artery. So if you can access an artery, you can get to the heart.
Very true.
So the big blood vessel in the leg was used because you could feel it. It was kind of easy to access with your equipment, and you also had the hip bone is right under that artery. So when you pull everything out, you can push pressure and hold pressure against the hip bone.
Wow.
That's the reason why it was done there. It also is big enough to deliver big equipment, so you can put huge pieces of equipment through that.
Wow.
But to do a heart catheterization, you don't actually need that big of a blood vessel.
Wow.
So it actually was probably 15 years ago that in other countries they started using the wrist. In the United States, that wasn't common. About 12 or 14 years ago, I started using the wrist.
Wow.
So, and now I do everything from that. So typically, to have a heart catheterization, a patient comes to the place where they're going to have it. An IV is placed, usually some blood is drawn. The person gets EKG patches applied to them, and then they're kind of ready to, and if there's hair in the location where the access is going to be, it's usually clipped. So then the person is taken back to the cath lab, which is a room that is, sterile. It's a sterile zone, we'll put it that way. There's kind of a big X-ray camera there that has the capability of making movie pictures. So not just a snap at X-ray, but it can make movie pictures. It also has heart monitoring equipment, so you can monitor the EKG and blood pressure and oxygen levels and all this. There's always a nurse there, and there's always a technician to help the procedure go, and there's somebody recording all the data. That's what a cath lab looks like, and then there's a doctor.
So mandatory.
So the patient lays on this table that's very, very comfortable, like an ironing board.
Literally.
So you lay it on the table. Most often, and almost everybody in America is converted to going through the wrist for a routine catheterization. So your wrist is cleaned up. You get some sedation through the IV on the other side. You're covered up with a bunch of sterile stuff, sterile drapes and whatnot. Sedation goes in. A person may not go to sleep, but they are often sort of in the twilight state, or at least not particularly anxious, and we give a little bit of pain medicine to mitigate any pain. Then usually the doctor's going to feel where the pulse is in your arm, give you a little titch of numbing medicine for the skin there, then punch a little needle into that artery right here. Then trade that out for a little tube. It looks like a little coffee stirrer. Through that tube, you pass the long, thin tube that goes all the way up to your heart. And after that tube is in place, a person typically doesn't feel anything anymore. So
Gotcha.
And honestly, this isn't that painful. So the pain associated with a cardiac catheterization is really
Like a needle stick. Not even.
it's very, very minimal now. Very minimal compared to what it was a few years ago.
Wow.
Going through the leg was uncomfortable. The line of people to do it for the fun of it's pretty short, but but it really is not that
It's
painful.
like at the fair, lining up for cats.
All right. So once that tube goes in, or actually when I get started, it typically takes me less than 5 minutes.
Wow.
So it's pretty fast. Occasionally, if a person's anatomy is not usual, it takes a little bit longer. But so about 5 minutes is how long it takes. So the tube goes up, positioned to measure the pressure or inject the X-ray dye. When you're injecting the X-ray dye, the camera will move around, the lights will go on and off, and all this is to allow the person who's doing the procedure to see what the X-ray camera is the pictures it's taking. And then everything comes out of the body, a little wristband goes on the wrist, all the stuff comes out, and then you're in the recovery area. And you don't even, back in the day when you went to the leg, the person had to lay flat for all this time. You can sit up in a chair now, go ahead and have your lunch or whatever. Get that cup of coffee you didn't get to have that morning.
Yeah. Is it MPO before cath lab?
Yes. So, and we'll see. One of these days we might actually study this, but the X-ray dye used to make people nauseated.
Oh.
So you didn't want people's stomach full going into the cath lab.
Gotcha.
That's still theoretically a problem, but boy, 30 years ago when we were doing this, it made everybody nauseated. So now the X-ray dye is better and it doesn't make people sick.
It's amazing how much has changed. I used to work in the hospital. This is 2014. Like when I worked with cardiologists back then, like everyone was still doing it here.
Yes.
And it's amazing. Just like when you were saying wrist earlier, I was like, what? Like in my mind, I was like, wow.
It's crazy. It honestly, it's
wow.
I will tell you that when I have it done, I'm going to get somebody who's good at it. But I'm probably not going to get.
You can't do it on you can't do it on yourself.
I'm thinking about it. But I may not even ask for sedation at all.
Wow, yeah.
Because I actually don't think I'd need it.
Wow.
I'd rather be cognizant of what's
And then
up.
once that tube, it just follows the artery all the way through.
That's right. All blood vessels lead to the heart, or it's not useful. So the heart pumps blood to the tissues. It pumps blood to the arteries.
All the way through.
So it's got to be connected to the heart. So if you can get into an artery, you can get to the heart.
That's really cool.
It is.
That's really cool.
And it's actually it sounds a lot harder than it is. Yeah. You want to do one?
Yeah. I do.
Come on over tomorrow. We'll have you doing one.
Cut. Get my doctor. Yeah, let's go. Man, that's really cool. Wow.
Yeah,
So I didn't mean to cut you off. You had another question, did you?
Let's see. I have a quick one. What trends have you seen from COVID? Were more people taking care of their health, or less, or were more people more active? Or?
Yeah, I think we have gotten finally, for the most part, to a post-COVID world. COVID was weird. And the biggest thing I think that COVID did, so there have been a few things in healthcare, in my time in healthcare, that have been very politically charged, and this was definitely the most politically charged.
Yeah.
And I am going to try to stay away from that as best I can. But I think that most people would agree that the public health officials were trying to convince people to adopt certain behaviors, whether it was getting a shot or wearing a mask or staying away or not going to Thanksgiving or whatever. And it turned out that a lot of that advice was not really probably as necessary as it was made out to be. Like, you're going to murder grandma if you go to Thanksgiving.
Yeah.
Well, that isn't so. And honestly, I think it's pretty clear that even those public health officials sort of knew it. So the public health officials and many doctors in general, I think, were telling people things that maybe at one, I don't think anybody was trying to hurt anybody. I think everybody was trying to help. But there were some things that were obviously not helpful, but it was kind of popular or politically correct to do so. And I'll use one example, is the paper masks. So if the flu virus is the size of Jupiter, the coronavirus is like the size of a Saturn moon, so it is going to fly through a paper mask like that.
Wow.
The paper masks, honestly, an N95 maybe was helpful. Okay, it seemed logical that maybe it's better than nothing, but we made it a big deal, and it's pretty clear. And honestly, that was kind of the time when I thought, boy, we're not doing the right thing here, because this is not true. I mean, if you know how a paper mask what it filters. I mean, you knew it wasn't going to, you just knew it was not going to filter a coronavirus. And I think that as a result, trust in healthcare in general has gone down. And I think it's been very injurious to doctor-patient relationships and people trusting pharmaceutical companies. And I think it's very unfortunate. Again, I don't really think that anybody was trying to be mean or hurt people or whatever. I don't think that. I think that hangover is still there. I don't think that a lot of the other lingering aspects of COVID are still there. I think we're over it for the most part now, which I'm grateful for.
Man,
Yeah.
that's a good question. Wow. Yeah, I was even thinking about like long COVID.
Yes.
Like those are. It's just like it's crazy because how the effects of that on the body, just like any other disease, right? Like, but it's amazing to see like how it truly affected the whole society as a whole.
Well, it did. Honestly, the thing is the virus for some people was horrible.
Yeah, really horrible. Yeah,
and for other people, it was kind of not much. And the thing that was most upsetting to me about the whole COVID thing is, as physicians, as applied scientists, we should be trying to come up with answers. And at the time, we weren't willing to do that. We were checking our brains at the door and listening to whatever the public health people said, even when at times it was pretty clear that what they were saying was questionable.
Yeah.
Let's leave it at that.
Yeah.
And I honestly don't know if this was going to help or that was going to help, and I don't really wish to go point fingers and prosecute, or even in my own mind, people who were, I think, genuinely trying to help. I'm disappointed in the healthcare providers in general that they weren't more curious.
Yeah.
Like, I can think for myself. I'm not. It doesn't make any sense that a medicine that we've used for a long time, for example, is all of a sudden harmful. And I'm referring specifically to Plaquenil, so I don't know if it helps. I don't have any idea.
Right.
But I know that it is not dangerous because there are thousands and thousands and millions of people who take this medicine.
Oh yeah.
Ivermectin was another one. I don't have any idea if it helps. I don't have any skin in that game. I would just like to know the answer.
Yeah.
And ivermectin, they say, well, it's a horse dewormer or whatever. Okay, well, that might be one of its uses, but its initial purpose was to cure river blindness in human beings. The guy who invented it won the Nobel Prize. It's perfectly okay to give it to human beings. I don't know if it's helpful. I don't know if it's more helpful or less helpful than the vaccine.
Yeah, the research
But let's
shows.
just ask the dang question.
Yeah.
And because this is hurting people, so let's help them, for heaven's sakes.
Yeah.
And that is the thing that was upsetting to me more than anything else.
Yeah, it's almost like fear turned off people's brains.
It did, and I think that is true generally in a society. Is sort of freedom versus security. That's a paradigm. It's two sides of the same seesaw, and I think different people have different risk tolerance and different desires for their own.
Right.
The question isn't so much how much freedom are you willing to limit yourself, but how much freedom am I willing to limit for you?
That's very true.
For the sake of my security and safety.
Yeah.
That's a better conversation to have.
It's almost like enforcing.
Of course it is.
Yeah. Wow, that's a good question.
Do you think people put more value on their health after COVID? Like it went up, or you think it went the opposite, or stayed the same?
I think it stayed the same. After it was, now that it's over.
During it, I feel like, I don't know. I guess there's two sides of the scale. Like a lot of people were like, let me go walk, let me go exercise in my room, let me do all this stuff. But then other people were just like, let me just lay in bed.
Yeah. So
for sure. Yeah. There's no question about that. I mean, there were different approaches to what we're going to do about this.
I feel like we ate less fast food too. That's personal
Yeah.
Yeah, it's variable. Yeah, it's very. There were all sorts of. It was such a nutty time,
true,
and there
yeah.
were so. Everybody had their own,
Yeah.
their own sort of take on it. I think. I hope that we can sort of put aside, sort of politics and pointing fingers at people, and go back and actually really learn something from
Yeah,
this.
analyze it.
I would love for us to learn. We taught one another to be afraid of our fellow man. That's a bad thing, And I mean, we. I'll tell you a story. I had patients who, this is kind of a little later in the pandemic, who were in nursing homes, who the only way they could ever leave the nursing home was go to a doctor's office. So I had some people who were in nursing homes, and they came because they needed they were worried about their blood pressure. So they came and they got their blood pressure measured. It's fine. I think you're going to be okay. We'll see you in 6 months. Can't we check it next week? Really, I think we're okay. And then they'd look over their shoulder. Doc, my daughter can't visit me unless I'm going to a doctor's office. But now she can visit me, pick me up. We can go shopping.
Crazy.
We come to you for 10 minutes. We can spend the afternoon together, and then I can go back and be locked up for another 6 days.
Man.
But for this day, I get to be with my daughter. That's awful.
Yeah.
So I checked that lady and many other people's blood pressure every week.
Wow. That's cool. Man.
So because that was awful. That was awful. We taught ourselves to be afraid of our fellow man. Yeah, that's bad. It really messed up some school kids, for example. Some young people are really messed up from that.
It's very true. Yeah.
Anyway.
I'm curious if they need to do like a deep study on like the whole everything that happened during COVID.
For sure. I mean, there's scientific and medical things we should study and all that, and for sure we should do that. But it also turned out to be a societal disaster.
We know that we're not prepared if there's
The reality is you're not going to be prepared, but maybe you can prepare your society, or educate your society about how or prepare to educate should the next thing come or whatever, such that our response can be a little more effective and can engender confidence and rather than fear.
Yeah.
Because that was a fear thing, It was not a really good way to set policy.
That's
I
a really
have
good point.
one quick
Yeah.
case study, I guess you could call it.
Yeah.
So I was in college athletics for the last 4 years, and after anyone had COVID, they were required before returning to play to get an EKG or an ultrasound.
Sure.
And my ultrasound came back with a mild tricuspid regurgitation. And my athletic trainer said to follow up in 6 months with it. And then when I went and saw my PCP, they said it's very common, and if my entire baseball team was screened, potentially 50% of my team would have something similar to what I had. So that it was very minor, and not something.
I would say it'd be 100%.
100%.
Wow.
Yeah, almost everybody has mild tricuspid.
Yeah.
Did a little
I
bit
have
of
one
tricuspid.
too. When I got screened playing D1, they had the same thing.
Yeah.
That's crazy.
Yeah, it's almost everybody has
Wow, I
a little
didn't
bit of
know that.
tricuspid.
Really?
Yeah, almost 100%. So I don't report it as an abnormality.
What is that?
So that's one of the heart valves. The tricuspid valve is the valve that separates the right atrium from the right ventricle. So the right atrium's job is to collect the blood, the venous blood from your body, and prepare to pump it into the lungs to be oxygenated again. So the collecting point is the right atrium. The major pump is the right ventricle. So in sequence, the valves have to open and close in proper sequence. So the purpose of the tricuspid valve is to collect that blood. When the ventricle starts to relax and it's ready to fill up with blood, that valve opens, supposed to let blood go through unimpeded. And then when the ventricle starts to close, so the blood doesn't shoot right back from where it came, it's supposed to close and keep the blood from going backwards. So that's its job. And it almost always lets a little bit of blood go backwards, just a little bit, just enough that you can record it on an echo.
Does it show up as like, what's a murmur? Can kind of go off of that. Is that?
So a murmur is a sound. So when a person says they have a heart murmur, that means that somebody stuck a stethoscope on their chest and they heard something that indicates turbulent blood flow. So the most common place where turbulent blood flow happens is at a heart valve, because the heart either doesn't open. The heart valve's supposed to open all the way, blood goes through unimpeded, close all the way, blood doesn't go backwards. So if the heart valve doesn't open all the way, it's restricted, then that's going to cause turbulent blood flow.
Gotcha.
And there'll be a sound. If it lets blood go backwards, typically, well, always, the chamber on the backside of a heart valve has less pressure in it than the one that's on the other side. Otherwise the valve wouldn't close. So that's a physics thing. So there, the blood is going to go backwards very fast, and that will make a sound. Now there can be other things. There can be holes in the heart and other stuff that cause murmurs, but the most common thing by far is either a sticky or a leaky heart valve.
Wow, which is the regurgitation you're talking about. That makes it, because when I had that, they said I had a small murmur, and then they found which makes sense.
The other thing is just rapid. So every pregnant woman practically has a heart murmur.
Wow.
Because they're pumping for two. So the flow rate's higher. One of the things that causes turbulent blood flow is the speed of the blood flow. So the more rapid the blood flow is, the more likely that there's going to be turbulent.
Moms
blood.
have bigger hearts.
Well, they actually can but
really,
this is the engineering thing. So there's a particular calculation you can make to determine if there's going to be turbulent flow. Wow. Yeah, I'll leave you the math aside.
That's a good question. That was a good question, JC. Wow. Well, y'all got any more? That's good. Cool. Great questions.
I have one more.
Yeah.
Okay.
So what are some common heart health misconceptions that your patients have? And I guess how do you address them or respond?
Oh boy. Well, there's a lot of those. I got to tell you, one of the biggest ones is about blood pressure.
Yeah.
So many people are worried. They see their blood pressure. One time they measured and it's 120/70, and the next time it's 140/80, and they feel like that's abnormal. That's not abnormal. The blood pressure is supposed to vary. It's not going to be the same. And you're really, when you're managing blood pressure within certain obvious limits, you're after an average. So if your blood pressure is high on one reading, but on 10 others it's normal, great. We're in a good place. But there are many, many people, and the thing of it is, if a person goes out and buys a blood pressure cuff and they don't learn anything about how to use it or what, first of all, they may not be making proper readings in the first place. If you don't do it correctly, you're going to get junk. Some people buy these little wrist things, which are less accurate, tend to read high compared to the ones that go around your upper arm, as another example. So I think because there is a consumer available device for purchase that's ubiquitous, and it doesn't cost as much as an iWatch or whatever. A lot of people have them, but they don't honestly really know how to use them or how to interpret the information. And it is, I think they're fantastic. I think it's fantastic to empower people to take charge of something in their healthcare. I think it's wonderful. I think it's terrible to give somebody something that they're going to use because they're afraid, not teach them to use it properly or when they should actually be afraid. You know, so the Apple Watch is not a medical device. That's another misconception. I know it's being sold that way, and yes, I'm not saying it's valueless, but it's pretty good if you're sitting still, not shaking your arm all over the place, not jogging down the road. You know, if you're doing those things, the reading is not going to be accurate. You know, so, and your heart rate also varies during the day. It's supposed to. You know, so there are some things that are out of the normal range that, you know, the blood pressure. So, for example, the blood pressure standards are written to monitor or measure your blood pressure when you've been sitting still, not lying, not standing, sitting still for 5 minutes.
Wow.
Not stimulated, not eating, not smoking a cigarette, not having a fight with your spouse, sitting still, not just having brought the groceries in, you know, for 5 minutes. How many people check their blood pressure like that? Yeah, so if you're checking it right after you carry the groceries in, it's supposed to be higher.
Yeah.
If it's not, that's actually abnormal. You know, if your
After the
heart
Cowboys lose.
there you go. If you measure your heart rate, you know, after you've just, you know, walked the dog, it's supposed to be high.
That's
supposed
a
to be.
good point. Yeah.
If you're asleep, your heart rate's supposed to go down. It may go down into the 30s.
Yeah, true.
And be perfectly normal, you know. I think that those are probably the most common things now that we have consumer available devices that have tremendous utility, but there needs to be something other than, you know, a 2-page instruction manual on how to use it. You know.
Yeah, that's so true. That's very true.
Yeah, I didn't think of that, where people will buy it. They'll get the right thing, but they just don't know how to use it.
How to use it. Yeah.
They don't know how to use
Then
it.
they
That's
get
right.
scared and get, I guess, anxious, and their blood pressure rises even more.
Yeah.
Well, you know, I was called once at 3 a.m. from a woman who, I love this lady. Truly, she was one of my favorite patients. But she was a little on the anxious side. She had a blood pressure cuff on each arm, and she was just checking her blood pressure.
Wow.
It's, you know, she was reporting the numbers as they were coming off, and it's like, please take the blood pressure cuffs off your arm and go to sleep. Your blood pressure will go down.
Yeah, yeah.
You know?
Oh man,
But,
it
you know,
kept going up.
So, you know, that's another thing. You know, I mean, you don't need to be checking your blood pressure 12 times a day. Once is enough. You know, there may be certain times when we need to monitor it more frequently than that, but for the most, a person will drive themselves crazy by doing this kind of stuff. They'll drive themselves crazy. You know, looking at your watch every 5 seconds to see if it's 86 now. No, it's 88.
Or like your watch, like nowadays, like notifies you too.
Yeah,
like,
yeah, that's true.
Stand up, go walk, or you know. And I guess then people get more invested in it.
For sure. Well, that kind of stuff is actually pretty good. Getting up to walk, you know, for example, there's no pump in your foot to pump the blood back up to your heart. So the pump is the muscles in your legs. So if you don't get up and walk, your legs are going to swelling is another common symptom that people get really upset about that very often has a relatively easy explanation. Not always, but you know.
That's really good. Yeah, that's a good question.
Those were all my questions.
That was great job.
Spent now.
Great question.
Cashed out.
Right. He'll send you the bill later.
It'll be cheap.
Right. Thank you for watching this episode of Charlin Care Pods. You can find Dr. Rick Ammar at www.heartplace.com and search Rick Ammar. Thank you so much. See you guys soon. Don't forget to like and subscribe.